Imagine you're sitting in the dentist's chair. You know, you've just been injected for what should be a perfectly routine procedure on your upper jaw.
Right.
But instead of your teeth simply going numb, you suddenly realize something is, well, terribly wrong. You can't move your eye.
Oh, God. Yeah.
You try to look up at that bright clinical light and your eye just refuses to track. You try to look down and it's physically locked in place.
It's terrifying for the patient.
Completely terrifying. The muscles controlling your eyeball are just paralyzed. And this isn't some freak 1 in a million accident, is it?
No, not at all. It's a known, highly predictable, and frankly, quite terrifying complication of a needle being pushed just, literally 1 millimeter too far into the wrong anatomical space.
Which brings us perfectly to today's topic. Welcome, listener, to another deep dive. Today, we are mapping the silence of the human face.
I love that phrase, mapping silence.
Yeah.
Because that sobering scenario you just described highlights exactly why we're here. Today's deep dive serves as a companion, a conceptual synthesis to Chapter 19 of the textbook of Head and Neck Anatomy by Hyatt and Gardner.
And just for context, in previous chapters, we mapped out the raw wiring of the cranial nerves, right? Where they originate, the bony canals they traverse, the tissues they innervate.
Spot on. But today, the mission shifts entirely. We're moving from the observation of that wiring to its targeted, deliberate interruption.
We're focusing on the anatomic basis for local anesthesia.
Exactly. And just to set the stage for you, the listener, whether you're an early years medical student grappling with the sheer density of your head and neck modules,
or a surgical or dental trainee refining your needle placement.
Right. Or even an experienced clinician looking to, solidify the structural reasoning behind your daily interventions, this is where the textbook actually meets the tissue.
Because we aren't here to just read off a list of foramina and nerve branches. You can memorize a table on your own time.
You really can. We're here to build a spatial, three-dimensional mental model of the face.
Yeah, because as that opening scenario with the paralyzed eye proves, if you don't understand the geography beneath the skin, your intervention goes from therapeutic to dangerous in a fraction of a second.
It does. And to frame everything we discussed today, we need to view local anesthesia not as a single isolated act, but as a carefully choreographed sequence of strategic roadblocks.
Strategic roadblocks. Okay, let's unpack this.
Well, to numb a patient with precision, you must first understand where the sensation lives and the exact physical pathways those sensory signals travel to reach the central nervous system.
So anatomy, in this context, is the study of structure in service of function.
Precisely. And today, the function we're serving is the temporary elimination of pain.
Wait, if the goal is just to stop the pain signals from reaching the brain, why do we bother hunting down these tiny, specific nerve branches in the first place?
What do you mean?
Well, if we think of the nervous system as a massively complex electrical grid lighting up a city, why are we trying to find the exact coordinates to safely snip one specific microscopic wire for a few hours? Why not just shut off the main power to the whole neighborhood? Or, to use the physical anatomy, why not just soak the entire quadrant of the jaw in anesthetic and be done with it?
Well, what's fascinating here is that the environment we're working in isn't a static, empty grid. The neighborhood is heavily vascularized.
Okay, so lots of blood vessels.
Exactly.
Yeah.
It's densely packed with competing structures and governed by systemic limits. If you simply flood an entire anatomical region with anesthetic fluid without targeting a specific nerve trunk or plexus,
the drug just goes everywhere.
It's rapidly absorbed by the surrounding blood vessels. And that leads to systemic toxicity, which we'll discuss later. Plus, it leaves the actual nerve you wanted to block perfectly functional.
Oh, right, because it washed away into the bloodstream.
Yes. So you must be precise. You have to intercept the signal at a specific anatomical choke point.
So to understand how we set up that roadblock at the choke point, we need to zoom all the way in, don't we? Let's talk about the cellular mechanism.
Let's do it.
We're taking a pharmacological agent and using it to temporarily break the physiological machine. The text defines anesthesia as the loss of sensation due to injury, disease, or drugs. But the actual mechanism for local anesthetics relies on something called membrane stabilization. How exactly does a liquid in a syringe stabilize a nerve membrane to the point of silence?
It comes down to the fundamental mechanism of how a nerve conducts a signal in the first place. Normally, a new fiber fires because of an action potential.
Right, a shift in electrical charge.
Spot on, a rapid shift in charge across its cell membrane, driven primarily by sodium ions rushing into the cell through specific microscopic channels.
Okay, so the sodium rushes in and the nerve fires.
Yes. And what a local anesthetic molecule does is physically enter those sodium channels and, well, jam them shut from the inside.
So it literally blocks the physical gate.
Exactly. It binds to a specific receptor site within the sodium channel. Because the sodium cannot rush in, the sudden change in electrical charge, the depolarization, never happens.
The membrane is stabilized in its resting state.
Yes. If a sufficient length of a nerve fiber is bathed in this solution and enough of those sodium channels are jammed closed, the electrical impulse traveling down from the tooth or the gum hits that stabilized section and simply dies.
The conduction is completely halted.
The brain never receives the signal, so the patient never feels the drill.
But the blackout doesn't happen instantaneously to every single nerve fiber in that bundle, does it?
No, it doesn't.
The text describes a very specific order of silence based on the physical architecture of the nerves themselves.
Right.
If you look at a cross-section of a nerve trunk, it's like looking at a bundle of different cables. You have small, unmyelinated fibers, and you have larger, heavily myelinated fibers.
And the local anesthetic doesn't treat them equally, which is a crucial piece of physiological luck for us.
Also,
well, the structure of the individual fiber dictates how vulnerable it is to the anesthetic drug. Myelin is a fatty, insulating sheath that wraps around certain nerves to speed up their conduction.
like the rubber coating on a copper wire?
Brilliant analogy, yes. Small, unmyelinated fibers completely lack this protective wrapper. Therefore, the anesthetic fluid diffusing through the tissue penetrates their membranes much more rapidly.
And functionally, what do those small, unmyelinated fibers do?
They're the primary carriers of pain and temperature sensations.
Oh, wow. Which means the exact sensation we most want to eliminate pain.
The very first to disappear.
Because those wires are the least protected. That's amazing.
It really is. Conversely, the larger fibers, the ones responsible for proprioception, the sensation of mechanical touch, and motor function, they are coated in thick layers of myelin.
So the drug has a much harder time penetrating to the sodium channels in those fibers.
Exactly. They are the last to succumb to the block. And sometimes, depending on the dosage and proximity, they aren't fully blocked at all.
You know, this explains a phenomenon that confuses so many patients.
The pressure thing.
Yes.
Yeah.
A patient will sit up and say, I can still feel you pushing on my tooth. The anesthesia isn't working.
Oh, I've heard that hundreds of times.
Right. But as a clinician, you know that feeling pressure is fundamentally different from feeling pain.
The pressure is traveling up those thick myelinated cables that are still somewhat functioning, but the unmyelinated pain cables have been silenced.
It requires immense clinical reassurance, doesn't it? You have to explain that tactile sensation and pain are entirely separate physiological pathways.
Absolutely. But consider what happens when the procedure ends and the drug begins to wear off. The recovery process.
Well, if the unmyelinated fibers are the easiest to block, are they the easiest to unblock? Do they wake up first?
Actually, no. The recovery happens in the exact reverse order.
Wait, really? Reverse order?
Yes. As the anesthetic gradually detaches from the sodium channels and diffuses away into the bloodstream to be metabolized, the concentration of the drug in the tissue drops.
Okay, that makes sense.
The large myelinated fibers, which required a high concentration to stay blocked in the first place, are the first to wake up.
So the patient will regain their sense of mechanical touch and motor control quite early on?
Spot on. The small, unmyelinated pain fibers, which are so incredibly sensitive to even low concentrations of the drug, are the very last to recover their conductivity.
So pain is the first sensation to leave the room and the very last one to come back.
Exactly. It's an incredibly elegant design feature of our neuroanatomy.
And one that makes modern dentistry and facial surgery possible, really. But getting the drug to those fibers requires different strategies depending on where we are in the mouth.
Definitely. The jaw is not a uniform structure.
The source text outlines 3 distinct tiers of delivery: infiltration, plexus anesthesia, and trunk anesthesia. Let's break these down, starting with infiltration, which the text notes is fairly restricted.
Infiltration is the most superficial approach. You're essentially targeting the microscopic terminal nerve endings directly in the tissue you want to numb.
You just inject a small amount of fluid just beneath the surface.
Right. However, this is largely restricted to soft mucous membranes. If you need to perform an extraction or a deep restoration on a tooth, infiltration won't work because it simply cannot penetrate deeply enough into the surrounding structures to numb the whole tooth.
Which forces us to move up a level to the second tier, plexus anesthesia.
Yes.
This involves delivering the anesthetic solution deeper into the connective tissue overlying the periosteum of the jawbone.
And the entire success of plexus anesthesia relies on a physical property of the bone itself. You deposit the fluid, and then you just have to wait for it to physically seep or diffuse through the microscopic pores of the bone.
To reach the dental plexus, the network of nerves sitting just above the roots of the teeth.
Precisely. And if the bone is too thick for diffusion, you are forced into the third tier, trunk anesthesia, commonly known as a nerve block.
This is a massive shift in strategy, isn't it?
It is. Instead of bathing the area near the tooth, you move anatomically upstream. You deliver the solution close to the main nerve trunk long before it even branches out into the plexus or the terminal endings.
By blocking the main highway, you numb absolutely everything distal to your injection site.
Everything down the line goes dark.
So what does this all mean? We have 3 tiers. Infiltration for surface tissue, plexus for seeping through the bone, and trunk blocks for shutting down the main highway.
Right.
The obvious question for any practitioner is, how do I choose? Does a clinician just pick their favorite method?
Not at all. The choice is entirely dictated by the bony architecture of the patient's skull. It all comes down to what we can call the bone divide.
The bone divide, I like that.
The maxilla, which forms the upper jaw, and the mandible, which forms the lower jaw, are structurally fundamentally different. You have to approach them with completely different strategies.
So how do we visualize this?
If we're visualizing this, think of the maxilla as a highly porous sponge and the mandible as an impenetrable, dense vault.
A sponge and a vault. That completely changes how you view a skull in an anatomy lab. Let's investigate the maxilla first. The sponge.
Let's do it.
The text notes that the maxillary buccal cortical plate, the outer layer of bone on the cheek side of your upper teeth, is wonderfully thin and cancellous.
Cancellous meaning it has a trabecular, honeycomb-like internal structure. It's full of spaces.
Right.
Because of this porosity, the maxilla is prime territory for plexus anesthesia. You do not need to hunt down the main maxillary nerve trunk deep in the skull.
You simply deposit the anesthetic agent into the loose connective tissue deep to the alveolar mucosa.
Exactly. You aim for the fornix, at or slightly above the mucogingival junction. Once deposited, the fluid easily diffuses through the cancellous sponge of the maxilla to bathe the dental plexus and numb the teeth.
But there is a crucial mechanical caveat here. The placement of the needle tip has to be incredibly precise regarding depth, doesn't it?
It really does.
If you inject too superficially into the loose connective tissue of the cheek, the agent just dissipates harmlessly and the tooth doesn't go numb.
Right, which is frustrating but not dangerous.
But if you inject too deeply, you hit the periosteum. And the text has a severe warning about superiosteal injections. Explain what happens if a clinician accidentally pushes the needle too deep and injects underneath the periosteum.
To understand the danger, you have to understand what the periosteum is. It's not just a loose wrapper around the bone. No, it's a dense, fibrous membrane that is tightly, intimately bound to the surface of the bone by strong collagen fibers. It's also highly vascularized and incredibly richly innervated with pain receptors.
Oh, wow.
If your needle tip passes through the connective tissue, pierces the periosteum, and rests directly against the hard bone, depositing fluid there is, well, it's catastrophic.
Because the fluid has nowhere to go.
Exactly. The fluid cannot immediately seed into the bone fast enough to accommodate the volume you're injecting. Therefore, the hydraulic pressure from your syringe physically rips the periosteum,
Tetanus.
along with its delicate blood vessels and nerve endings, right off the surface of the bone.
That sounds viscerally horrifying.
It feels viscerally horrifying to the patient once the local anesthetic wears off. Tearing the periosteum creates an immediate superiosteal hematoma, a pocket of blood trapped tightly against the bone.
So that results in immense, throbbing, long-lasting post-operative pain.
Yes. It's a mechanical injury caused entirely by poor depth control. You must inject into the loose tissue overlying the periosteum, allowing it to act as a gentle reservoir for diffusion rather than using fluid pressure as a crowbar.
Right, so the maxilla is a sponge, but it requires finesse to avoid tearing its highly sensitive wrapper. Now let's look at the lower jaw, the vault.
The mandible is a completely different landscape. The mandibular cortical plate is incredibly thick. It's dense, compact bone.
Why is it so different?
Well, it has to be. The mandible takes the massive biomechanical force of the muscles of mastication. It's a lever arm designed to crush food, so evolutionary pressures have made its outer shell incredibly dense.
And because of that density, diffusion through the thick mandibular bone is virtually impossible.
With the occasional exception of the very front, near the incisors, where the bone thins out slightly. But generally, yes, impossible.
Which means our strategy of plexus anesthesia depositing fluid and waiting for it to seep through is completely useless for the mandibular molars and premolars.
Utterly useless. You'll just numb the cheek and the gums, but the pulpal tissue inside the tooth will remain fully sensate.
Because the bone is an impenetrable vault, you're forced to use trunk anesthesia.
Exactly. You have to locate the main nerve trunk before it enters the bony vault of the mandible, or find specific foramina where branches exit the vault. For the mandible, nerve blocks are not optional. They are the mandatory method of choice.
But before we dive into the specific geography of those blocks, there's a shadow hanging over this entire discussion, a hazard that exists every single time a needle penetrates facial tissue.
The golden rule of safety.
Yes, the non-negotiable critical step, aspiration. We mentioned earlier that we don't just flood the mouth with anesthetic because of the vascular network. The text lays out some statistics that should make any practitioner stop and take a breath.
If we connect this to the bigger picture, it is alarming.
It states that almost half of the mortality in dental offices is linked to the administration of local anesthesia to sensitive patients or accidental intravenous injection. Almost half.
It is arguably the most dangerous thing a dentist does on a routine basis. Aspiration is the singular mechanical technique designed to prevent that catastrophe.
Walk us through it.
When you advance your needle to the target site, before you push the plunger to deposit the drug, you must pull back on the thumb ring of the syringe by just 1 to 2 millimeters.
You're creating negative pressure inside the syringe cartridge.
Yes. You're asking the tissue a question. Am I inside a blood vessel? If the needle tip is resting in loose connective tissue, pulling back will just draw a tiny microscopic bit of tissue against the bevel, and nothing enters the cartridge.
But if you're in a vessel?
If your needle tip has pierced the wall of a vein or an artery, that negative pressure will instantly draw a plume of dark red blood back into the glass cartridge. That is a positive aspiration.
If you see that bloom of red, the rule is absolute. You do not inject, you withdraw, reposition, and try again.
Never inject.
But let's play out the worst-case scenario. What actually happens if a practitioner is rushing, skips aspiration, and accidentally injects a full cartridge of local anesthetic directly into a facial vein or artery?
The consequences are immediate and severe. You've bypassed the slow controlled diffusion process entirely. The drug goes systemic instantly.
And since local anesthetics are sodium channel blockers?
If a massive bolus hits the heart, it starts blocking the sodium channels in the cardiac muscle, leading to severe arrhythmias or cardiovascular collapse.
Goodness.
And when it hits the central nervous system, it can cross the blood-brain barrier, causing profound neurological toxicity. This often manifests as severe convulsions, followed by central nervous system depression, respiratory failure, and potentially death.
And even if it isn't a lethal dose, the mechanical trauma to the vessel is a massive issue.
Absolutely.
Yeah.
If you penetrate a large artery, such as the posterior superior alveolar artery, the arterial pressure will pump blood out of the puncture hole rapidly.
Into the face.
Yes. Within minutes, the patient will develop a massive extraoral hematoma. The side of their face will swell drastically, and because the fascial spaces of the head and neck are interconnected, that hemorrhage can dissect downwards into the tissue planes of the neck.
Potentially compromising the airway.
Yes. A routine filling turns into an airway emergency in 3 minutes because the practitioner didn't pull back the thumb ring for 1 second.
That is exactly why we're dwelling on this. This is the reality of applied anatomy.
Quite right.
So, with the golden rule of aspiration firmly locked in our minds, let's navigate this map. Let's start by systematically breaching the maxilla. We know it's a sponge.
Right.
We're aiming for the loose connective tissue above the periosteum to achieve plexus anesthesia. The text details the 3 alveolar nerves we need to target: the anterior, middle, and posterior superior alveolar nerves. Let's start at the front.
Anteriorly, we have the anterior superior alveolar block, or the ASA. The territory for the ASA covers the central incisors, the lateral incisors, and the canines.
Mechanically, this is relatively straightforward, isn't it?
It is. You palpate the area above the roots of these anterior teeth, lift the lip, and insert the needle at or slightly above the mucogingival junction. The cancellous bone here is very thin, so diffusion to the dental plexus is highly predictable.
Moving backwards, we hit the premolar territory, which is the domain of the middle superior alveolar block, the MSA. The target site is just below the apex of the second premolar. But here is where it gets really interesting.
Ah, yes, the MSA.
The anatomy refuses to be simple. The text points out a brilliant, frustrating anatomical quirk regarding the MSA. It's only present as a distinct nerve in about 28% of the population.
It's a remarkable developmental variation. In over 70% of your patients, there is no discrete middle superior alveolar nerve.
So how do the premolars feel anything if the nerve doesn't exist? Do they just lack sensation?
No, the nervous system builds redundancies. When the MSA is absent, the superior dental plexus, which is a vast, communicating web of nerve fibers running through the maxilla, simply bridges the gap.
Like a backup generator.
Precisely. Fibers extending forward from the posterior nerves and backwards from the anterior nerves intertwine to cover the premolar region.
But if 72% of people don't have it, why do we even give it a name and a specific block technique? Why not just rely on the overlap?
Because of the 28% who do have it. When the MSA nerve is present as a distinct, independent branch dropping down from the infraorbital canal, it doesn't just neatly innervate the premolars and stop. No, it extends further back. It actively assists in providing sensory innervation to the mesial buccal root of the first maxillary molar.
The mesial buccal root, the root on the cheek side facing forward. And that tiny detail creates what we could call the first molar problem when we move to our next block, the posterior superior alveolar block, or the PSA.
Exactly.
The PSA is designed to target the 3 maxillary molars at the back of the mouth. The technique involves delivering the solution high up in the vestibule through the mucosa of the fornix at the level of the second molar, angling upward, inward, and backward.
You want to bathe the PSA nerve just before it enters the tiny foramina on the back of the maxilla.
But let's say a dentist executes a flawless PSA block. They wait the appropriate time. They start drilling into the first molar, and the patient screams. Why?
Because of that 28% anomaly. In a patient with a discrete MSA nerve, the PSA block will beautifully numb the second and third molars, and it will numb the back half of the first molar.
But it will completely miss that mesial buccal root.
Because that specific root is getting its live feed from the MSA nerve further forward.
You essentially have a tooth with dual power supplies. You cut one wire, but the other is still live.
Exactly. And the clinical trap is that you cannot know by looking at an X-ray or looking inside the mouth whether a patient falls into that 28% category. The anatomy is invisible until you test it.
So what's the solution?
Clinical best practice dictates a rule of redundancy. If you are performing a profound procedure on the maxillary first molar, such as a root canal or an extraction, you must proactively block both the PSA and the MSA nerves to guarantee complete anesthesia. You anticipate the anatomical variation.
That is the essence of this entire deep dive, anticipating the invisible variations. But the PSA block isn't just tricky because of overlapping nerves. It's physically one of the most hazardous plexus blocks in the mouth due to the vascular real estate at the back of the maxilla.
It is quite perilous.
When you push a needle upward, inward, and backward behind the zygomatic process, what are you risking hitting?
You're entering the infratemporal fossa, which is incredibly crowded. First, you have the pterygoid plexus of veins. This is a massive, sprawling network of veins.
That's intimidating.
It looks intimidating on a diagram, but the text notes that the veins are relatively forgiving if you maintain strict technique. If you keep the needle tip sliding closely against the bony curvature of the maxilla, you generally slide safely past the venous plexus.
But there is a much less forgiving structure lurking right there.
Yes. The posterior superior alveolar artery. It descends directly across the posterior surface of the maxilla alongside the nerve. It is a significant arterial vessel.
And if you stray away from the bone...
If you stray too far laterally away from the bone, or if you advance the needle too deeply, you risk puncturing this artery.
And as we discussed with our golden rule, puncturing an artery at the back of the maxilla means high-pressure bleeding into a loose anatomical space. It creates a rapid, massive hematoma.
The patient's cheek will visibly swell before your eyes.
If a clinician does this, they can't exactly put a Band-Aid on it, but the text gives a vital physical intervention strategy to staunch that deep bleeding. How do you stop invisible artery from hemorrhaging?
You have to use the surrounding anatomy as a vice. If you recognize a rapidly forming hematoma following a PSA block, you immediately use your fingers to exert firm, sustained physical pressure on the outside of the face.
Where exactly?
Specifically, you press inward against the maxilla at the anterior border of the masseter muscle, just inferior to the zygomatic arch.
You are basically trying to crush the tissue against the bone to compress the artery and stop the flow.
Precisely. You're using external landmarks, the masseter and the zygomatic arch, to blindly locate and compress an internal vascular emergency. It requires a profound spatial understanding of where that artery sits in three-dimensional space relative to the skull.
Okay, so that covers the delicate sponge work of the maxillary plexus blocks. You have to dodge the PSA artery, anticipate the MSA ghost nerve, and avoid tearing the periosteum.
Right.
But what if we want to bypass the sponge entirely? What if a surgeon needs to work on multiple teeth and the surrounding tissue all at once?
They move to maxillary trunk blocks.
Let's look at the infraorbital, or IO, nerve block.
The infraorbital nerve block is a brilliant piece of anatomical leverage. The infraorbital nerve is a major branch of the maxillary nerve. It travels through the floor of the eye socket and exits the skull through the infraorbital foramen right onto the front of the maxilla.
And as it travels?
As it travels, it gives off the anterior superior alveolar nerve and, if it exists, the middle superior alveolar nerve.
So by targeting this one exit hole, the infraorbital foramen, you can knock out a massive territory with a single injection.
The scope is highly efficient. A successful IO block provides profound anesthesia of the central incisor, lateral incisor, and canine in 100% of patients. And because it often catches the origin of the MSA, it will also numb the premolars in about 72% of the population.
Plus, it numbs the side of the nose, the lower eyelid, and the upper lip.
It covers a lot of ground.
To perform it, a clinician has to locate that tiny hole beneath the skin. The text says to palpate the orbital rim, find the zygomaticomaxillary suture, the seam where the cheekbone meets the upper jawbone, and feel just inferior to that for the bony ledge curving underneath. That's your target.
Correct.
But this brings us back to the horrifying scenario we opened the episode with, the paralyzed eye. How does an injection aiming for the teeth end up locking the eyeball in place?
It is entirely an issue of depth control and bone density. The infraorbital foramen isn't just a flat hole on the surface of the bone. It's the opening of a canal that runs backward into the floor of the orbit, the eye socket.
And the bone forming the roof of that canal.
The bone separating the nerve from the actual eye socket above it is paper thin. In some individuals, it is practically translucent.
So if a clinician is overly aggressive, trying to ensure the fluid gets as deep into the canal as possible,
the needle will physically perforate that thin, bony roof. It snaps right through into the orbit. And when the plunger is depressed, the anesthetic solution is deposited directly into the periorbital fat surrounding the eye.
And bathed in that periorbital fat are the extraocular muscles. Specifically, the inferior rectus and the inferior oblique muscles, which control the downward and upward movement of the eyeball.
Because the local anesthetic stabilizes the membranes of motor nerves as well as sensory nerves, bathing those muscles in the drug temporarily paralyzes them.
So the patient suddenly experiences diplopia double vision and a terrifying inability to elevate or depress their eye. The globe is mechanically tethered by paralyzed muscles.
It is a profound clinical error. It will wear off as the drug metabolizes, but the psychological distress for the patient is immense.
Yeah.
It proves that you must respect the physical boundaries of the anatomy. You aren't just aiming for a nerve. You are actively avoiding the orbit.
Right. Let's move away from the cheek and look at the roof of the mouth, the palate.
Ah, the palate.
The mucosal tissue on the palate is notoriously difficult to anesthetize comfortably. We have two primary blocks here, the greater palatine and the nasopalatine.
Let's start posteriorly with the greater palatine nerve block. This nerve exits the greater palatine foramen, which is located on the hard palate, roughly midway between the midline roof of the mouth and the gingival margin of the second or third molar.
Okay, so it sweeps forward, innervating the palatal mucosa and bone all the way up to the canine tooth.
Yes.
So you simply find the foramen, stick the needle in, and inject, right?
Emphatically no. You actually want to avoid entering the foramen itself. You deposit the solution slightly anterior to the foramen.
Why? If the nerve comes out of the hole, why not put the drug exactly in the hole?
Because of what lives right behind it. Just posterior to the greater palatine foramen are the lesser palatine foramina, which transmit the lesser palatine nerves.
And what do they do?
The lesser palatine nerves do not supply the hard palate. They supply the soft palate and the uvula. If you inject directly into the greater palatine foramen or use too much volume, the fluid easily tracks backward and bathes the lesser palatine nerves.
And numbing the soft palate sounds like it would just feel weird, but it actually triggers a massive physiological defense mechanism, doesn't it?
It does. The soft palate is highly sensitive and critical for swallowing. If it goes completely numb, the patient loses the sensory feedback of where their soft palate is.
Oh, I see.
For many patients, this sensory deprivation triggers a severe, uncontrollable gag reflex. They feel as though their airway is swelling shut or that they're choking. even though their airway is perfectly open.
That sounds awful.
It's a panic-inducing sensation, and it makes it functionally impossible for the clinician to continue working the mouth.
It's another example of collateral numbness. You aimed for the hard palate, but you disabled the software that keeps the patient from gagging on your instruments.
That's a good way to put it.
Moving to the front of the palate, we have the nasopalatine nerve block. The nasopalatine nerve descends through the nasal cavity and exits onto the roof of the mouth through the incisive foramen, which sits directly behind the two central incisors.
It supplies the anterior triangle of the hard palate between the canines. A single injection right in the midline anesthetizes both the right and left side simultaneously. It is incredibly efficient.
But the text makes a very specific point about the patient experience here. It is brutal.
It is widely considered the most painful injection in dentistry. And the reason is purely structural.
Because of the tissue density.
Exactly. We talked earlier about injecting into loose connective tissue to allow for diffusion. On the anterior hard palate, there is no loose connective tissue. The mucosa is a dense fibrous pad that is tightly bound directly to the underlying maxillary bone to withstand the friction of chewing.
There is zero slack in the tissue.
None. When you introduce a volume of fluid from a syringe into that space, it has nowhere to go. The hydraulic pressure forcefully dissects the tight mucosa away from the bone and the nerve endings. It is a tearing pressure.
Ouch. So how do clinicians handle it?
To mitigate this, clinicians are taught to deliver the solution incredibly slowly, drop by drop often, applying intense physical pressure with a cotton swab adjacent to the needle.
Why the cotton swab?
They try to distract the local pain receptors with mechanical stimuli before the fluid enters.
Ah, the gate control theory of pain trying to overwhelm the nerve with pressure so it doesn't process the tearing pain of the fluid. Even then, the profound wooden numbness of the anterior palate is highly discomforting.
It is.
Okay, we have successfully navigated the maxilla. We used the porous sponge to our advantage. We dodged the PSA artery, avoided paralyzing the eye, and carefully skirted the gag reflex. But now the rules change entirely. We must breach the dense armor of the mandible.
The vault. The mandible is a vault of thick cortical bone. Plexus diffusion is useless here. We're relying entirely on finding the main nerve trunks before they're hidden inside the bone.
And the absolute king of mandibular anesthesia is the inferior alveolar nerve block, almost universally referred to as simply a mandibular block.
It is.
The target here is the inferior alveolar nerve, right before it dives into the mandibular foramen on the medial or inside surface of the ramus of the jaw. This is a blind injection. You cannot see the foramen. You have to use the soft tissue and bony landmarks as your guide.
And the landmarks are highly specific. The mandibular foramen is guarded by a small tongue of bone called the lingula, which serves as the attachment point for the sphenomandibular ligament.
Okay.
The clinician must palpate the retromolar pad, the fleshy area behind the last molar, and the pterygomandibular fold, which is a band of tissue stretching from the upper to the lower jaw. You pierce the mucosa between these two landmarks, aiming for a spot just above the lingula.
When you hit it perfectly, the scope of this single injection is staggering, isn't it? Because you're blocking the main trunk before it splits, you numb the inferior alveolar nerve itself, which knocks out all the pulpal tissue of every lower tooth on that side.
Right.
You knock out the incisive nerve, the mental nerve, which numbs the lower lip and chin, and because of its anatomical proximity, you almost always numb the lingual nerve, which knocks out the interior 2/3 of the tongue. It's a massive quadrant-wide blackout.
It is highly efficient when it works. But this raises an important question about efficacy. The text outlines several significant, frustrating challenges with the IA block. It's notorious among clinicians because it has a surprisingly high failure rate.
Really? How high?
Studies show that 15 to 20% of the time the anesthesia is inadequate. The patient still feels pain.
Why is it so inconsistent? If the landmarks are there, why does the block fail 1 out of every 5 times?
Because human anatomy is not printed from a single factory mold.
Yeah.
The inadequacy largely stems from vast anatomical variations between patients.
Variation in the bone structure.
Yes. The exact anterior-posterior location of the mandibular foramen, its height relative to the occlusal plane, the flare of the mandibular ramus, these all vary significantly. The soft tissue landmarks we rely on can be misleading if the underlying bone is shaped unusually.
So your needle might be exactly where the textbook says it should be, but the nerve is a centimeter further back.
Exactly. Furthermore, there is the issue of accessory innervation. The inferior alveolar nerve might be perfectly blocked, But some mandibular teeth, particularly the molars, occasionally receive rogue sensory branches from the mylohyoid nerve.
Oh, and that branches off before the foramen.
Yes, before the mandibular foramen. The IA block completely misses it, leaving a backdoor channel for pain signals.
And let's revisit our golden rule. The IA block carries the highest positive aspiration rate of any intraoral technique. The text puts it at a staggering 10 to 15%.
It's an incredibly vascular area. The inferior alveolar artery and vein run right alongside the nerve into the foramen. Because you're aiming blindly for that exact bundle, the chances of your needle tip entering the vein or artery are phenomenally high.
So 1 in 10 times or more, you will draw blood into your cartridge.
You must withdraw and start again. If you fail to aspirate here, you're injecting a massive bolus of local anesthetic directly into the bloodstream.
Which leads to the systemic toxicity we discussed earlier. Add to all this the patient experience. The IA block is uncomfortable. Having half your tongue and your entire lower lip profoundly numb for hours is distressing.
Patients, especially children, are at high risk of accidentally chewing their numb lip to shreds because they cannot feel the damage they're causing.
Because of these drawbacks, and because the IA block doesn't cover absolutely every piece of tissue in the mandible, clinicians use complementary mandibular blocks. You mentioned the lingual nerve is often caught during the IA block, but what if you need to be sure?
A dedicated lingual block is very simple. The lingual nerve lies just anterior and slightly medial to the inferior alveolar nerve. Often, a clinician will administer the IA block, and as they're withdrawing the needle from the deep tissue, they'll pause halfway out.
Just to deposit a little more fluid.
Yes, to purposefully bathe the lingual nerve on the way out.
But the IA block and the lingual block still miss one crucial area of the mandible, the cheek-side gums of the molars.
Yes, the buccal mucoperiosteum. The inferior alveolar nerve runs inside the bone, but the outside of the bone, the gums facing the cheek, are innervated by a completely different branch, the buccal nerve, or long buccal nerve.
Where is that?
It crosses the anterior border of the ramus at about the level of the upper molars.
So if you're extracting a lower molar, you need an IA block for the tooth, a lingual block for the inside gums, and a buccal block for the outside gums. You are literally surrounding the tooth with roadblocks.
You are. The text notes the buccal block is highly successful, near 100%, but it has tripwires. Well, the tissue overlying the anterior border of the ramus is thin. If the clinician injects too deeply and hits the periosteum, it's quite painful. Furthermore, the needle can easily penetrate the tendon of the temporalis muscle, which inserts into the coronoid process nearby.
And hitting a muscle tendon.
Injecting into a muscle tendon causes significant postoperative trismus, a severe stiffness or lockjaw effect that can last for days.
It is a landscape of hidden tripwires. Finally, let's look at the anterior mandible, the front of the jaw. We have 2 blocks that target the exact same anatomical hole, the mental foramen, but they achieve 2 radically different results, the mental block and the incisive block.
Both techniques target the mental foramen, which is located on the outside of the jawbone, usually just below the apex of the second premolar. The mental nerve is a terminal branch of the inferior alveolar nerve that exits this hole
to supply sensation to the soft tissues of the lower lip, the chin, and the front gums. If a clinician simply deposits fluid into the mucosal tissue near the second premolar, letting it bathe the nerve as it exits the hole, that is a mental block. It's a soft tissue block. It numbs the lip and the gums, but it does absolutely nothing for the teeth themselves.
Because the pulpal tissue of the front teeth is innervated by the other terminal branch, the incisive nerve, which never leaves the bone. It stays inside the mandibular canal, traveling forward from the mental foramen toward the midline.
So here is the clinical dilemma. You need to drill into a lower incisor. You don't want to give the patient a full, tongue-numbing inferior alveolar block just for one front tooth. You want to use the mental foramen. But the nerve you need to numb is hiding inside the bone, behind the hole. How do you reach it?
This is where we transition from a simple mental block to a true mandibular incisive nerve block. The technique relies entirely on applied fluid dynamics and biomechanics. The clinician inserts the needle into the mucosa at the mental foramen and deposits a larger volume of anesthetic solution.
But it's just sitting on the outside of the hole.
Exactly. So immediately after retracting the needle, the clinician uses their thumb or index finger to apply firm, sustained physical pressure to the outside of the patient's face, directly over the injection site.
This is one of my absolute favorite details in the text. It's like creating a localized pressure washer effect. You're physically massaging the fluid, forcing it to act against the anatomical current.
That's a great way to describe it.
The external finger pressure forces the anesthetic liquid backwards, physically pushing it into the mental foramen, flooding the anterior portion of the mandibular canal so it can bathe the hidden incisive nerve.
It is a masterful example of applied anatomy. You're taking a passive pharmacological agent and using external biomechanical force to alter its internal flow path, based entirely on your knowledge of a 2-millimeter opening in the bone.
It perfectly encapsulates what we've been discussing. Anatomy isn't just about knowing the names of the structures, it is about knowing how to manipulate them.
Absolutely. To synthesize all of this, the maxilla, the mandible, the vascular hazards, the anatomical variations, what becomes vividly clear is that the face is a highly overlapping, redundant, and perilous network. A single intervention rarely acts in isolation.
It's a dynamic system. You must constantly anticipate collateral effects. You aim for the upper teeth, but a millimeter of thin bone is all that separates you from paralyzing the extraocular muscles.
You aim for the hard palate, but a few drops of fluid drifting backward can trigger a violent gag reflex.
You aim for the back molars, but you have to anticipate that 1 in 4 patients has a rogue MSA nerve bridging the gap. Clinical success is the marriage of detailed, three-dimensional anatomical knowledge and precise, disciplined, unyielding technique.
You must respect the bone density, you must understand the nerve pathways, and you must, without fail, respect the vascular hazards.
Which brings us perfectly to our review section. Let's cement this knowledge and make sure these pathways are locked in. I'm going to pose 5 single best answer questions directly to you, the listener, based on the core principles and clinical hazards we've just explored. Take a moment to think of your answer, and our expert will break down the why behind the correct choice. Let's start with the cellular level.
Ready when you are.
Here is question 1. Which nerve fibers are typically the first to be functionally blocked by the administration of local anesthetics? Is it A, large myelinated fibers, B, motor fibers, C, small unmyelinated fibers, D, proprioceptive fibers, or E, tactile fibers?
The correct answer is C, small unmyelinated fibers. As we discussed regarding the order of silence, local anesthetics must penetrate the nerve membrane to block the sodium channels. The smaller fibers lack a thick, fatty myelin sheath, making them highly susceptible to rapid penetration and membrane stabilization. Because these specific unmyelinated fibers primarily carry pain and temperature sensations, clinical pain relief is achieved before the larger myelinated motor or tactile fibers are entirely lost.
Excellent. Moving to the maxilla, question 2. Complete pulpal anesthesia of the maxillary first molar often requires blocking the posterior superior alveolar nerve A and D, which other structure, due to an anatomical variant present in roughly 28% of patients. Is it A, greater palatine nerve, B, anterior superior alveolar nerve, C, middle superior alveolar nerve, D, nasopalatine nerve, or E, infraorbital nerve?
The answer is C, the middle superior alveolar nerve. This addresses the first molar problem. In the 28% of the population where a discrete MSA nerve exists, it provides sensory innervation specifically to the mesial buccal root of the first maxillary molar. Therefore, a PSA block alone will leave that specific anterior root unanesthetized. A supplemental MSA block is required for profound anesthesia of the entire tooth.
Question 3. Addressing a major clinical hazard. During an infraorbital nerve block, the patient suddenly experiences double vision and an inability to elevate or depress their eye. What specific anatomical error occurred? A, penetration of the pterygoid venous plexus. B, perforation of the infraorbital canal roof. C, spurious steel injection tearing the connective tissue. D, injection into the lesser palatine foramen. Or E, laceration of the PSA artery.
The correct choice is B, perforation of the infraorbital canal roof. The bony floor of the orbit, which serves as the roof of the infraorbital canal, is incredibly thin. If the needle advances too deeply or aggressively into the foramen, it easily breaches this bone. The anesthetic solution is then deposited directly into the periorbital fat, bathing and temporarily paralyzing the inferior rectus and inferior oblique muscles, which mechanically tethers the eye.
Question 4. Looking at biomechanical technique. A clinician aims to numb the pulpal tissue of the mandibular incisors without performing a full quadrant-wide inferior alveolar block. They inject at the mental foramen. What crucial final step must they take to ensure pulpal rather than just soft tissue anesthesia? A, aspirate 3 separate times. B, apply firm finger pressure to the extraoral site. C. Inject an additional cartridge at the lingula. D. Pierce the periosteum forcefully. Or E. Advance the needle blindly to the retromolar pad.
The answer is B. Apply firm finger pressure to the site. Simply injecting at the mental foramen performs a mental nerve block which only affects the external soft tissues of the lip and chin. To achieve an incisive nerve block for the internal pulpal tissue of the anterior teeth, the clinician must apply external finger pressure to physically force the anesthetic fluid backwards, against the current, through the foramen, and deep into the mandibular canal where the incisive nerve travels.
And our final question, question 5. A patient begins to gag uncontrollably, feeling as though their throat is closing, after an injection aimed at the hard palate posterior to the premolars. What is the most likely anatomic explanation for this distress? A. The nasopalatine nerve was unusually bilateral. B. The solution diffused upward through the maxilla into the nasal cavity. C. Solution was injected too close to the greater palatine foramen, overlapping and blocking the lesser palatine nerves. D. The pterygoid venous plexus was breached, causing rapid swelling. Or E. The lingual nerve was inadvertently blocked.
Correct answer is C. The intended target was the greater palatine nerve to numb the hard palate. However, if the injection is placed directly into or too closely adjacent to the greater palatine foramen, the fluid easily diffuses posteriorly to the lesser palatine nerves. Numbing the lesser palatine nerves desensitizes the soft palate and uvula, which removes sensory feedback and frequently triggers a severe, uncontrollable gag reflex in the patient.
Brilliant. We spend so much time in our early studies looking at anatomy as a static, colorful map in a textbook, a simple legend of what is where. But today, hopefully we've broken that map open. We've seen that anatomy is actually a highly dynamic landscape of resistances and permeabilities. The density of a bone, whether it acts as a porous sponge or an impenetrable vault or the microscopic variation of a nerve branch, doesn't just change a diagram. It dictates physical reality. It dictates whether your patient feels peace or agony, safety or toxicity. As you step into the clinic and look at your next patient, don't just see the surface structures. See the invisible pathways you have the power to control.
Spot on.
Here are the details of this episode.
Anatomic basis for local anesthesia. Mapping silence in the face. Byline. To numb with precision, you must first understand where sensation lives and how it travels. Episode description. If Chapter 18 gave us the wiring of the cranial nerves, this chapter teaches us something far more practical. This chapter teaches us something far more practical, how to interrupt that wiring safely, deliberately, and effectively. This chapter teaches us something far more practical. This is not just anatomy. This chapter teaches us something far more practical. This is applied anatomy, where knowledge becomes intervention. This chapter teaches us something far more practical. This chapter teaches us something far more practical. It is a carefully choreographed sequence. This chapter teaches us something far more practical. This chapter teaches us something far more practical. Key takeaways. This chapter teaches us something far more practical. Local anesthesia blocks nerve conduction. This chapter teaches us something far more practical. Pain fibers are blocked first. This chapter teaches us something far more practical. Maxilla yucca, diffusion works.
This chapter teaches us something far more practical. Mandible requires nerve blocks. This chapter teaches us something far more practical. Each block targets a specific anatomical pathway. This chapter teaches us something far more practical. Aspiration is critical for safety. This chapter teaches us something far more practical. Clinical success depends on anatomy plus technique.